Hello, everybody, and welcome to How to Run a Hospital in the Midst of a Pandemic. We are going to wait a few moments for all of you to virtually file in, and then we're looking forward to hosting you at this event. All right, welcome everyone. My name is Carmel Shafar, and I'm the Executive Director at the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. I am delighted to welcome you today to our virtual event, How to Run a Hospital During a Pandemic, Hospital Administration, Ethical and Legal Challenges in the Time of COVID-19. Before we get to the meat of the substance, a few housekeeping items. The first and most important item that we're going to go over is how to ask questions. Because this is a moderated discussion, I will be asking questions of our three panelists. We have some questions prepared that we think are interesting, but we really welcome your questions. You can do that in one of two ways. There is the Q&A feature in Zoom, so please feel free to use that. The question that you pose won't appear to other attendees, but it will appear to me, and I assure you I will be reading it very, very closely. I'm very good at multitasking. The other way to send your question to us is to go on Twitter and join the Twitter discussion. Our handle is @Petrie-Flom, and the Twitter hashtag that we will be using for the event is #HospitalAdminCovid. So if you post a question at #HospitalAdminCovid, I will again be multitasking and reading the Twitter, and I will pull those questions. I see that somebody has used the raise hand feature on Zoom. The icon is very cute. I think that as a university, we miss being in classes and having people raise their hands, but we will unfortunately not be using that feature, nor will we be using the chat feature. So now that we've covered how you can get a hold of us, a few other housekeeping items. The Petrie-Flom Center is really committed to bringing you interesting content, especially as the fields of health law, policy, biotechnology, bioethics change so rapidly in light of the pandemic. If you found us through some alternate route, I strongly suggest that you sign up for our newsletter. It comes out only twice a month. We are very, very religious in holding firm to not spamming your inboxes, and it's the best way to find out about other events. For example, next week on July 8th, we're going to have a really interesting discussion on the role of advanced care in the COVID pandemic, including talking about people who are in their 20s and 30s, who are thinking about advanced care in light of the increased health risks, as well as what does advanced care look like during a time where there's a lot of disruption to the healthcare system. The following week, we are about to announce an event on the recent Supreme Court abortion case, June Medical, as well as reproductive rights in the COVID-19 era. We hope you will join us for that conversation. And then a week or two after, we'll have a follow-up event looking at reproductive rights in the time of COVID in Latin America. So even though it's summer, it's not summer vacation for us. Please join us at those events. And now let's talk specifically about the event that you're here for. Hospital administration is a really complex thing during the best of times, but I think even more so now during the pandemic, when hospitals are thinking about how to respond to the surge of COVID-19 patients, including how to obtain enough supplies, how to manage their workforce, as well as they're facing challenges in a sharp decrease in revenue from a pause on other medical procedures. We wanted to bring together some hospital leaders to reflect on all of the challenges that are facing our healthcare institutions during this pandemic. I will start by introducing our esteemed panel. Ladies first, of course. We have Rena K. Spence, former president and CEO of Emerson Hospital in Concord, Massachusetts, and advisor to the Precision Medicine, Artificial Intelligence, and the Law Project here at the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. We also have joining us John Fernandez, president of Massachusetts Eye and Ear at Boston, Massachusetts. And then to give us a little bit of somewhat geographic diversity, we are joined by Bruce Bland, president and CEO of Medicis Health Network in Queens, New York. So Rena, Bruce, and John, I want to thank you very much for joining us. I'm going to ask you to unmute, and we are going to kick off this discussion with a very broad question. We all know the role that physicians and nurses play in the hospital. They're the people who take your temperature and tell you that you should maybe eat a little less and run a little more. What do hospital administrators and leaders typically do?
I'd be happy to share with you from my perspective as the CEO of our organization. We get involved in all aspects of the organization, but it all starts with quality and patient safety. We are also responsible for the finances of the organization and the overall strategic direction of the hospitals and the other subsidiaries. Ours is a safety net organization, and that's always in the definition. So I'll just share with you my definition of a safety net, where our payer mix is 60%, 60% Medicaid, 20% Medicare, 5% uninsured, and 15% other. And just to give you a further idea of the financial challenges that we have across the country, the average number of days of cash on hand for a hospital is typically 260. Our days of cash on hand is 5.
That is quite a difference. I imagine that safety net hospitals oftentimes have a different role in the community than some other hospitals. Do you think that's the case, Bruce?
Oh, absolutely. Well, so I can talk from a pretty longitudinal perspective, having been with our organization 45 years. And the disparities and inequities in the healthcare system have really been highlighted as part of the COVID crisis. The challenges that people living in our community confront, I think, are quite different than those that people in more affluent communities face. And our folks are faced with that every single day of the year.
I'd add a couple of things. Mass Eye and Ear is a teaching hospital at Harvard and part of the what's now called the Mass General Brigham Health System. Used to be called the Partners Health System. A couple other things I would just add to what Bruce said about strategic planning and those matters is, as nonprofits, we also, the presidents are responsible for fundraising is another part of and we also have research in our organizations and teaching. So we have a 3-part mission. Sometimes it's referred to as a 4-part mission if you include community, teaching, research, and patient care. So I just thought I'd add those couple things to Bruce's comments.
So Carmel, if I could just add, because there seemed to be a little bit of interest regarding safety nets. So in our community, the folks living in our community are faced with socioeconomic challenges that lead to poorer health outcomes. Medical care really addresses about 20% of that, but the social determinants of health, like unemployment and education and housing and homelessness and food insecurity, really are the bulk of the challenges that the people in a community like mine confront on a daily basis.
So if I could touch on sort of another support system in administration, I would say we can't forget the role of the board. And that, we have boards of trustees that are entrusted with really supporting the work of the CEO in the hospital and carrying out their missions and their goals. And I think the area of concern that I would raise and maybe discuss with you or later is the difference between those boards of a not-for-profit and those boards of a for-profit. Because the boards that you work with as not-for-profits are essentially members of your community. And so they are helping you run your hospitals and make decisions for members of your community. Members of the board of a hospital that is a for-profit, their community are shareholders and investors. And how they make decisions is probably quite different than the not-for-profit board. If you want to go, we can go into that a little further, but I just want to point out that they are a key arm in helping the system.
I think that is a good overview of some of the different hospitals, as well as the role of hospital administration in different types of hospitals. Before we dig too deeply, I think, into the points that you raised, Rena, let's talk about the pandemic specifically. How is hospital administration in a pandemic different than during more normal times?
Let me take a shot at that if I can. So we always have challenges because of the financial distress of our organization. So we live in crisis day to day, but during the COVID-19 crisis, that was even further exacerbated. But for us, we're very fortunate that we have a terrific team that's been together for on average 25 years. The CFO, myself, the Chief Medical Officer, Chief Operating Officer, our Vice Presidents, and the Chairman of the various departments really work together very effectively. There's a tremendous amount of trust between the team members, and that's allowed us to do a lot of things in terms of making rapid decisions. And during a crisis, you really have to make rapid decisions. And we've learned that over the years because we have a long history of responding to disasters. That started in 1992 when we sent teams of people down to Homestead, Florida after Hurricane Andrew. In 2001, we had some of the first ambulances on the scene after 9/11. As a matter of fact, one of our ambulances was so early on the scene that it was crushed when the tower came down. Fortunately, our medics were out of the vehicle. We had people on the ground in New Orleans after Hurricane Katrina in 2005. And then most recently in 2020, just in February, in response to a request from Governor Cuomo, we had teams on the ground in Puerto Rico like we had in 2017 after Hurricane Maria, this time helping with the mental health needs of the people of Puerto Rico. So we've learned a lot from those disaster responses and how to operate in a crisis. And we've used those lessons during the COVID crisis to get us through these challenges.
So John, how would you say that hospital administration has changed in the last several months?
So a couple points I'd make is one is it varies a lot by institution and what your patient mix is. So take, for example, a specialty hospital, we saw an 80% decrease in our patient volume. 90% of our researchers went home and worked from home. So dramatic change in what's going on at that institution. But we also then started taking COVID patients from our next door neighbor, the Mass General, on one of our floors. And we also sent some of our staff to other hospitals to help them. Turn that around, you go to a general hospital and you saw the ERs full, the ICUs full, the beds full, but operating rooms being used as places to house patients. Primary care clinics shut and relying on telemedicine. So the variation of where you were in the healthcare system was very different in terms of that experience. The other thing I'd point out, and Bruce probably uses some, I don't know which system you use, but the other thing that changes at a hospital is you go to a sort of a command center, and they're different systems, but they by and large are sort of more of a very top-down decision-making, and sometimes it's the team there. For us at Mass General Brigham, we had a system-level command center, and then each hospital had their own command center. So as Bruce pointed out, you make quick decisions, and sometimes you realize you made a quick decision and you have to change it the next day. There's daily communications, and there's a whole hierarchy set up in advance that everybody sort of practices and hates to use, but these situations come up. We were actually, and this sort of touches on maybe something we'll get to later, is we were actually in a command center mode because we were having a supply problem with surgical packs at Mass Eye and Ear and around our region. So COVID came along, and we just sort of kept our command center open. Now, COVID was much worse than the supply problem we were having with surgical packs, but it can come up in the strain, floods, fires. You never know when you're going to be when you're going to be needed.
So I think John made a really important point, that you make the best decisions that you can based upon the information that's available to you at the time, but that information can change rapidly. So for example, the biggest challenge that we had during the COVID crisis was when we peaked at the end of March, beginning of April, and our bulk oxygen system was threatened because we had 3 times the number of patients on ventilators that we have on a normal basis. So at that time, we had 500 positive COVID patients admitted to our hospital. 150 of them were on ventilators, 90 on our Jamaica campus, 60 on our Flushing campus. And Jamaica, by the way, is a level 1 trauma center, a stroke center. They do advanced cardiac services, but we never had 90 patients on a ventilator before, and that was threatening the bulk oxygen system. So we had to make a very rapid decision. We did it in conjunction with the governor's office and the health department, that we needed to rebalance the load. And since every hospital in New York City was on overload, and we were at the epicenter in Queens, we needed to transfer patients out of the hospital. So what we did was we rapidly transferred patients up to the Albany region, which is 150 miles north of Queens. And we did that successfully over a 1-week period of time. We transferred 108 patients, 45 of whom were on ventilators, and another 30 of whom ended up on ventilators. We also transferred patients successfully to the USNS Comfort, which was the naval ship that was docked in Manhattan. We were the first hospital to send them ventilator-dependent patients. We sent them 11 patients and overall 29 patients. And then we, probably more than any other hospital in the city, utilized the Javits Center, which was a field hospital. And we sent them 68 patients, 6 of whom were on ventilators. So over a 3-week period of time, when we were so heavily occupied, we ended up transferring 232 patients, 75 of whom started off on ventilators, another 70 who ended up on ventilators. But we were always guided by what was in the best interest of the patient. You know, we never thought about finances, we never thought about reimbursement. For us, it was always doing what was in the best interest of the patient.
So Bruce and John, I think both of your recent answers touched upon the idea of cooperation between different institutions. John, in terms of the partners Mass General Brigham system, which is a very large interconnected system, and Bruce, in terms of thinking what resources are available to balance out the load. How usual or unusual is it to be thinking in terms of region as opposed to your specific institution?
So Partners Healthcare, now called Mass General Brigham, is a $15 billion health system. I forget, we have about 14 hospitals, rehab facilities, everything you can think of. and is also founded by the Mass General Hospital, which is a huge, almost 1,000-bed facility, as well as the Brigham and Women's Hospital, also a huge teaching hospital. So having two teaching hospitals, we could go into a whole nother discussion about how entertaining that is. But I think the cooperation around the city and the state was pretty terrific. There were sharing of information, much more than normal. Sort of the competitive parts of it, they still existed, but it was really dropped, and people came together. We had every other day, or Monday, Wednesday, Friday, the MHA, which is our lobbying organization, sort of served as a convening group so that you could discuss different regions' problems. The western part of the state is much more rural, as most of you know, whereas you have the urban environments on the eastern part of Massachusetts. So really felt like people came together both inside the system, but also regionally, and sharing information and patients and working with the Department of Public Health. And during the crisis, I've found in hospitals throughout my career that people rise to the occasion. When there's an emergency, that they're the first people that step forward and fix that problem, whatever that is. We get back to normal, we compete and do the normal stuff, but I think that's a great tribute to the profession and the industry of healthcare, is that we're here to serve. And everybody, I think, really did that in Massachusetts. We had patients transferred in and out of different hospitals that hadn't happened in years. Rehab hospitals, taking patients from acute care, standing up the hospital, Boston Hope, which was a field hospital, sort of the same way they did in New York, a huge facility in a week, 10 days. And that took a lot of cooperation from all over we even had the football team flying in PPE. So, everybody pitched in.
So our system is just a little bit different than John's. We're a two hospital system, and we have a long-term care facility, very extensive ambulatory care. So our story is a little bit different. We had extraordinary cooperation. A lot of that was facilitated through the governor's office and the state health commissioner, because, as I said, every hospital in New York City was on overload. So the ability to transfer patients outside of the city was something that really produced terrific results and really saved lives. What I attribute a lot of that to is the value of relationships. You can't overstate the value of relationships, working with the governor's office, the commissioner's office, the mayor's office, the Hospital Association in New York State, Greater New York Hospital Association, the American Hospital Association. And I was able to pick up the phone, call my counterpart at Albany Medical Center and say, Dennis, any chance that you might be able to take some of our patients? And within 10 minutes, he said yes, and they already had the helicopters ready to go.
So I have two questions from an incoming Petrie-Flom student fellow, Laura Karras, who her first question is, what challenges do hospitals face in adding bed capacity? Laura also wants to know your thoughts on certificate of need laws, in that many states have relaxed their certificate of need laws to permit increases in bed capacity. What do you think about the immediate relaxation, and perhaps what we could learn about certificate of need laws moving forward in the future?
Carmel, may I just go back to the last question and conversation for one comment?
Absolutely.
So I want to say that I think both New York and Massachusetts are blessed with extremely good leadership at the state level and at the hospital level. And that being said, those are both states with primarily not-for-profit institutions who share mission. They may compete, but they share the same mission. I would want to know, as we move to other parts of the country, what happens when that kind of central leadership is not as strong, and where the division of the not-for-profit community hospitals, teaching hospitals, and many private hospitals exist, you know, is there that level of cooperation? Because I think what the two are telling us, what Bruce and John are saying, it's because they have that set of relationships. They have a common culture of cooperation, and they have good leadership, which enabled through COVID for these hospitals to come together.
Rena, I think you make excellent points. And in New York State, I don't know if the audience is aware, there are no for-profit hospitals in New York State. Thank you for the kind words about the leadership. But our mission is really aligned with the other hospitals in the community. And you had made earlier reference to a for-profit board's mission, and they're beholden to the shareholders. We're beholden to the community, so we always try to do what's in the best interest of the people who live in this community.
Yes. So, all right, we'll come back to that later if we wish, but thank you.
So
yeah, I think that is a useful discussion, but in the meantime, let's just detour back to Laura's question about capacity.
So if I can, and it was an excellent question, the governor of New York, Governor Cuomo, mandated that we create overnight surge capacity 100% over our usual capacity. So a surge capacity involves space, supplies, equipment, and staff. The first three are easy. The fourth, creating staff, is the most challenging. But we were able to double the bed capacity of both of our institutions, and that proved to be critically important as we were inundated with patients. There was one day I remember where on one of our hospital campuses, in the emergency department, we had 79 admitted patients waiting for a bed upstairs, and every bed, including the surge beds, were occupied. Just to give you a sense of how busy it was. And I totally agree with the person who asked the question. If we could have a simple process to get the CON approved, that would help greatly.
Yeah, I'd add, on the CON or DON process, we had great cooperation from the state to change rules, laws, suspend this thing or that thing, whatever it might be. I think it points to, in the future, the process, the torture that we go through on DON and CON processes, I think are very outdated, and we might even look to how those might be refined so it's not torture, it's just better public policy, at least here in Massachusetts.
So Bruce, your comment of having 79 patients and needing to figure out who to send upstairs brings me to a section that I like to think of as you are in your bioethics class and you are facing the toughest test that you perhaps can. We have audience questions asking about how did you discuss ventilator prioritization, decision maker, and that is a real to unpack. As two other questions that are similar that ask what sort of ethical challenges did you face and what were the most difficult ethical dilemmas that you faced as administrators?
So I'm sorry, some of what you said got frozen, but all of our decisions were always in the best interest of the patients, and they were all made based upon all the clinical information that was available. And I think that the patients were extraordinarily well served. Oftentimes, in cramped quarters. But I don't know of any adverse events that resulted from the challenges that we confronted at the time.
Rena, you want to add anything?
Sorry,
Did you want to add anything before?
No, I'm good on that. Thank you.
I think the other thing we did across the health system and even through the region was work on the what if situation where you had to start to make the really tough decisions of limited resources, severely limited, where you start to have to choose who gets an ICU bed and who gets to live or die. And we came up with a set of criteria that eventually got, reviewed by all the hospitals, the state, and engaged in that process early on. There had been a document that people had been working on, but COVID sped that up so that there would be some open dialogue about how those decisions would get made. Because that's really, we didn't get to that spot in Massachusetts, but that's the spot when people really were sort of worried about the ethical dilemma of who gets the resource and who doesn't. But that's why we surged capacity, built Boston Hope, and did all these things so we didn't have to face that decision.
We had a similar experience to what John just elaborated on, that we had a committee that we set up. We had a bioethicist that was involved, but we never got to that point. We always had enough space, supplies, and equipment. We fortunately never ran out of PPE. We always made that a #1 priority for us because we wanted our team members to feel safe and protected and supported. There were times when we had to have the governor's office procure disposable gowns, for example, but they were able to access the stockpile for us. So we never ran out of anything, and we were most fortunate. But as John said, we did have the discussion. We just never needed to implement that.
So speaking of difficult decisions, we have a question about visitation policies. So how did you make the visitation policies in the COVID-19 era? What considerations did you take? Do you have end-of-life exceptions for visitation? And do they apply to COVID-19 positive patients as well?
So in New York, that was pretty easy because it was determined by the New York State Commissioner's Office and by the Governor's Office, where they eliminated all visitation except for end-of-life patients. And as a matter of fact, it was only within the last week that we got guidance to reestablish visitation. It's now permitted on a 4-hour per day basis. And we have done that now throughout the hospital. During the crisis also, they allowed one individual to be with a pregnant mom during the birth experience.
We had a similar, it was good to have the state take the lead on that process, slightly different rules, and we just relaxed those to be now one visitor for outpatient and for inpatient. But similar, that's a really good one. If you want to put down the lessons learned, having the state make those decisions is a good thing.
So that's actually an interesting point to explore. Where did you feel like the hospital, the medical system, government collaboration worked really well in response to the pandemic? And where do you see room for improvement?
So if you want to, not to sound repetitive, but I think the example that I gave you with regard to the transfers was probably the best example that I have. Within a matter of minutes, we were able to get a process in place where one of our colleagues and their facilities were able to take our patients. Some of that was facilitated through the governor's office and the commissioner's office in terms of providing transportation and other support. We were able to provide them with medical record information. Both institutions use Epic, so that was facilitated that way. But I can't overstate how important the cooperation was.
I'd say the place in Massachusetts, if I had to reflect, would probably be in the sort of nursing home community. There are a lot of deaths, a lot of problems, and I'm not sure. I think if we look back, we could have done better by that community. But the nice thing is in Boston, for Massachusetts and for our hospitals, is the capital is Boston, and so the governor's right there, the mayor's right there. It really did help facilitate communication and also I would also say the biotech community, at least here in Boston, was a huge help with PPE and just trying to be helpful here as well as the state and city governments.
So I actually want to talk a little bit about long-term care and nursing homes, even though that's not your area of expertise, because it's such an important part of the COVID-19 epidemic. Friend of the center, James Little, asked, based on what you know now, what would you have done differently? Any thoughts on what went wrong in the long-term care nursing home sector?
So maybe I could start on that because we do have a long-term care facility. We have a 228-bed nursing home on our campus. We were extremely supportive of them. Whenever they had a really sick patient, they would transfer them to the hospital. And I think that prevented some mortalities. And overall, I don't want to jinx us, but overall, very fortunate throughout the entire crisis. At the nursing home, there were only 3 patients in the nursing home that expired.
May I comment? Am I on here? Okay, off mute. I think I'm going to come back to the same point I was making before on the leadership, because the nursing homes, many of them are private. And so sometimes they are not as coordinated as Spalding is, or as some of your attached nursing homes. And that even brings the point, I think, home closer, which is absent leadership and absent that coordination. We either don't know what's going on in those institutions, we can't help them fast enough, and we can't move patients fast enough. And that out of today, what one of my hopes would be is that, given that we are seeing nationwide a crisis continuing in other states, that the lessons learned from today's discussion, especially with John and Bruce from 2 leading states, can help people mitigate a crisis that they may be getting into now.
Just one little factoid. I forget the name of the company, but it'll come back to me. But the company out in Seattle, where COVID sort of got its start in Seattle, is the same company that managed one of the nursing homes here in Massachusetts that got into a lot of trouble. I don't think that's a coincidence. It's staffing. It's just the industry. It speaks to. I think the issue there is leadership. Yes,
and values.
And there's corporate structure and stuff like that.
Corporate structure and values.
But you can be for profit and be a good neighbor. And nonprofit, you don't really have a choice. But I would say we have good for-profit neighbors and we have not so good. And we saw it come through in the nursing home area.
Yeah, I would agree with both Rena and John on that.
So by popular demand, I think the audience wants us to talk a little bit about PPE. We have somebody who flagged the story of a hospital administrator who had to drive across 2 states to secure PPE. John, you mentioned that even before the pandemic started, the partner system was trying to source more surgical packs. What are the pressure points in obtaining sufficient PPE, and what lessons do you think we've learned and will implement moving forward?
So I think for us, it definitely being in a large health system, so sort of size mattered in obtaining resources and having a sophisticated supply chain. We had problems, and we have a pretty good supply chain. And we were learning from the surgical pack one. Our international dependency, it's an international world, but we probably need to think about our dependencies if the planes are limited and so forth and so on, because in surgical packs we had a supply chain problem getting surgical packs, and they were mostly being done in China. That doesn't mean China's bad. It just means when you're relying on multiple systems, you need to have pretty good redundancy. And I would think probably a lesson learned or an issue to figure out is, how do we scale the production of face masks and some very basic stuff? Sort of concerning that we had to sort of rely on like Bauer Hockey to make new face masks, and we couldn't gear up. We couldn't gear up to get face masks and gowns. Seems to me to be, we ought to, as a country, be able to figure out what could we do to gear that up. My daughter was making face masks. It doesn't seem like the best way to create face masks on your home, homemade products. She made a little money, but yeah, that was good.
So I think staying ahead of it is critically important. So in New York State, for example, our governor has already determined that on a going forward basis, all hospitals have to have at least a 90-day supply of PPE. So we're in the process of ramping up for that. But I think that, in preparation for what we anticipated in this crisis, we started accumulating PPE very early, and I think that helped us out a lot.
Rena, I know that as somebody in Boston who is a friend of the rich biotech scene in Boston, you've given a little bit of thought as to what the biotech industry might do to contribute to a solution to this problem. Would you like to talk about that being a piece in the PPE solution?
Well, I think that you have, at MIT, you have at other institutions around here, everybody focused on what they can do through this COVID, and PPE development and invention has been a big one. I think there will be solutions coming out around the PPE area, and I think we just need to get the biotech community and the sort of innovations community to move them faster. And whether they require FDA approval, I'm not sure, but I see some starting to come out now. But I think we do have an opportunity. Going back to what John said, I mean, the issue with being dependent on China or anybody is you get stuck. And so we need to have solutions that are based here and quick and that are cheap. And I think the innovations community, which we'll call that, is coming up with that.
So
yeah, we brought to bear in Boston this huge machine to clean, to do cleaning down right next to the corporate headquarters, but that was a huge help. And to be able to clean face masks, there are a lot of logistics of doing that, but being able to reuse some of them and having our innovation folks figure out, well, how can we make it so you don't have to throw everything out? We do have.
John, I just saw one brilliant innovation, which was in fact a reusable face mask. Right. It is now going through a process. Maybe even in a couple of weeks, we'll be ready for prime time. That's exactly what's being looked at and being worked on by some really good young entrepreneurs.
Totally agree.
So we have several questions, including one from a former Petrie-Flom student fellow, Golly Katz-Nelson, about balancing the need of COVID-19 patients with other patients. So she wants to know how hospitals are managing the backlog of elective procedures while COVID is still with us. And then there are other questions asking about how do you balance the need of patients in existing provider-patient relationships not involving COVID versus the needs of new and future COVID-19 patients.
Well, that's a doozy. So let me just I'll take a couple comments on that. One is that I think the backlog versus the existing, we have, most of the hospitals I'm aware of have extended hours. At Mass Eye and Ear, you'll love this marketing. We had Cataract Saturday. So we did cataract surgery to try to deal with the backlog of people that had signed up for surgery over this time to sort of catch up. So I think we're using every trick. I think telemedicine helped. People thought of it as an innovation. I hope we don't think of telemedicine or Zoom medicine as something new and novel. Now we can just do that going forward and make the patient experience even better, and have our payers pay for it. Because there's a lot of stuff that you don't have to come into a hospital or facility. So I'd hope a couple of those things would, on the process side, would be better for our patients. But you can't do everything by telemedicine. I mean, you still have to examine people. X-rays can't be done on a computer yet. And surgery and other things still need to be seen by a human being. So I hope we learn a lot from this effort. And that's how I would start to triage the patients who really needs to be seen, and how we deal with the backlog versus the existing. Last point I make is we saw a lot of patients throughout our health system that postponed care that they really shouldn't have. We had several amputations for diabetic patients that didn't come in quickly enough. Cancer patients that didn't get into screen. I mean, there's some problems when people don't use the health system. That doesn't mean everybody should have come in, but there are groups of patients that decided to vote with their feet, but probably set themselves back a little bit.
So we also used telehealth considerably, ramped that up very quickly for primary care visits, telepsychiatry, as well as urgent care visits. But I'd like to share with you, for us, our value-based payment and capitation strategy was extraordinarily important over the years, but really during this crisis proved to be a very important strategy. We take full capitated risk on 154,000 individuals. We have a whole care management program that's set up to keep them healthy and well. And over the course of the COVID crisis, our care management team was in constant contact with all of our capitated patients, talking to them about their food needs, talking to them about doing depression screening. Oftentimes, our care management teams were the only ones communicating with these individuals. There were a number of times where our care managers ended up learning that they were speaking to recently widowed and widowers because their loved ones had died in the hospital alone, and we provided a tremendous amount of support because of the relationship that we've built with them over the years as part of this capitated program.
So we have this very thoughtful question. So hospitals are institutions that consist of diverse staff that serve diverse communities. What specific measures have you seen taken to address healthcare inequalities and disparities that were pronounced during this pandemic?
So I'll take a shot at that one. So it's been reported widely in the media about how disproportionately impacted people living in socioeconomically challenged and minority communities they've been compared to people in more affluent communities. And we've seen that firsthand in our community. As I said earlier, it's the social determinants of health that really are in imbalance between more affluent communities and those communities like we serve. And we have been working for years trying to right that. But unfortunately, it seems like the gap just keeps widening between the haves and the have-nots.
I could add that I think during this period, so there's the COVID crisis, there's the financial crisis that it has caused, the racial unrest protests are going on now. We have a market and an election period. So that all equals a ton of uncertainty. And I would say any one of those problems makes running a hospital or healthcare system much more difficult. You know, all 3 or 4 of them together add to the difficulty. I think the one sort of positive outcome is that it was a wake-up call to leaders in healthcare that I have to do better when it comes to health disparities and health inequalities. We do a lot in Boston, but you know what? When you reflect on it, you go, not enough, not clearly good enough. And I think if we could take a positive out of all this mess, when we go back to how we prioritize our work, where we spend our money, where we spend our capital, who we hire, who's on boards. I'll give you a simple example, search processes in an academic medical center, which some of you might be aware of if you are somewhat affiliated with Harvard. Most of those search committees say, well, you have to have professors on the professorial searches. Well, guess what? Not very diverse. So if you have all the people on the search committee not very diverse, guess what happens to the search process? And you can go on and on this. So there's simple little things that we can do as systems, as higher education, whatever it is, that we can make things better if we challenge some of the assumptions of how we run our organizations, who we hire, et cetera, et cetera. So if there had to be something good that's come out of this, I hope that there's sustained action across the board, not just a bunch of posters or loosely held commitments, that our leadership across the country has sustained action, not just talk.
So let me add to what John said. If your audience is not familiar, Queens County, where our organization is located, is a population of 2.3 million people. It's the most culturally diverse of the 3,000 counties in the United States. The people of Queens speak 135 different languages. My 6,500 employees speak 100 of those different languages. You know, we are challenged all the time because of the financial makeup of this community. Over the last decade, we lost 6 of the 15 hospitals that serve this population. That's 40% of the hospitals went out of business because they couldn't financially make it. So if we've learned anything, it's that I think that we have to protect the safety net, because when a hospital closes, the problem doesn't get solved. It just gets shifted, and it just exacerbates the problem that the hospitals in those communities were confronting before those other hospital closures.
So I would just, if I may, just sort of give an overarching comment, which is many of the issues that you brought up really sort of focus on staff morale. And that to the extent that you as leaders can resolve the issues that we are facing in the society, because the hospital is a microcosm, and it will be a microcosm of all the issues that the outside the hospital are facing. And I think your leadership in that will speak volumes to how the institution will function, and good staff morale will make quality patient care.
So Rena, I agree with you completely, and I'm going to quote our vice chairman of family medicine, because she's probably talking right now to incoming residents, and what she says to them right from day one is, if you're mission driven, this is the place you want to be. If you're not, you ought to go and look someplace else now. So we're very fortunate that most of the people that work here and have worked here for decades are truly committed to the well-being of this population in this community.
So we have over 30 really excellent questions, but I'm mindful that we only have 2 more minutes and that you guys are very highly scheduled. So I'm going to end with the question that it's no secret that COVID rates are exploding in the South and in the West. As leaders in the Boston and New York communities that sort of faced the initial rush of the pandemic, what advice would you give your counterparts sitting in, say, Texas or Arizona?
Wear masks.
Plan some more, and try to get the kind of support and leadership that has been provided in New York State. I think the results speak for themselves.
So Rena, do you have any concluding thoughts or well wishes to our Southern and Western counterparts?
I come back to it. It's about leadership, it's about cooperation, and it's about rising above everything that you've been doing and focusing on the people.
Yeah, I'd add one more thing in that this is a public health problem that you should solve as a public health problem, not a hospital problem.
Correct.
And it just takes a different lens of where you put your time, energy, and money.
That's right.
You know, by the time a patient gets to a hospital, it's a little late with COVID.
Yeah. Yes. Community leadership, statewide leadership, national leadership.
So with that, our time is up. I really want to thank you 3 for giving up an hour in your very busy days to participate in this really interesting conversation. Our audience had a ton of questions that you guys did really great at answering. Although if you have more questions, audience members, please continue the conversation on Twitter. We would love to see a robust discussion. For those who were like, that conversation was great, I wish that my friends could have seen it. Once that we have this video properly captioned so that it can be accessible to a broader swath of our community, we will be posting it online. So please check the event page where you registered, and once we have the captions, we will post the video there. And again, a big thank you to Rena, Bruce, and John. That was great.
Yeah.
Thank you so much, Carmel, for putting it together.
Yes, really good.
Compliment Rena and John. Thank you so much.
It's great, Carmel. Thank you.
Take care.
All right. Have a lovely day, everyone.